And I'm going to talk a little bit about the history of ECP, but I'll skip over how it works because certainly that's been covered very nicely in the previous talk, but a bit about safety, how we use ECP and CTCL, the guidelines, and some real-world evidence on the use of ECP. We lack any large randomized trials with ECP, so looking at real-world data can be a great way of understanding how best to use it. So I like this slide because it's always nice to see colleagues who have aged well. So this is Rick Edelson back in the day when in his lab he created the first ECP machine with the idea that PUVA was a great treatment for mycosis fungoides. How about if he treated the blood of patients with Sézary syndrome with PUVA? And he created this machine that we see here in the lab, and then Therakos took this over and developed the first machine for ECP. It worked very well for erythrodermic patients, 83% response rate, which has been pretty stable throughout the time since, and it was rapidly FDA approved. That rapid FDA approval probably prevented any good randomized controlled trials in ECP because suddenly it was just there being used, it worked, and so people went with it. We've seen this. I think the most amazing thing about ECP is, unlike most drugs, it can improve with time because you can make the machine better. So we have seen this history from the EVAR machine to the XTS machine and the CellX machine, where each time it's a little bit better. The CellX machine has the advantage of continuous flow, so it goes in one arm and out the other arm, which speeds up the treatment. It means there's less volume shifts, so it just takes, an hour and a half. You don't get the hypotension that you can see with the XTS, and a better separation of the buffy coat. So a treatment that can improve, although stay the same under the same label of ECP. It's very safe, which is why we like it. So compared to some of the other treatments for Sézary syndrome with slightly worse adverse effects, most patients may get a mild headache, if anything, some photophobia, again, rarely, and more significant side effects are rare and tend to be infection-related or due to volume fluid shifts. So who do we treat with Sézary syndrome? Well, we treat patients with erythrodermic disease or Sézary syndrome. These patients have terrible intractable pruritus, as well as nail dystrophy and ectropion. And when we looked at a meta-analysis of 41 studies of patients with ECP in the literature, we found a mean response rate of 63%, with complete responses in 20%. And the literature really confirms the efficacy of ECP in erythrodermic CTCL. But the response rates do vary depending on the studies. Sometimes there's different stages of CTCL being treated, sometimes early, sometimes just erythrodermic, sometimes Sézary, sometimes MF. And where you treat in the treatment schedule can be important. Are you using the ECP up front? Are you reaching to it as one of your first-line therapies? Or is it being reserved for a more refractory disease? So in summary of the literature, it's been used since 1987. And real-world data has shown consistent response rates around 60%. It's well tolerated with few significant side effects, and very importantly, no increased risk of second malignancies or infections. But does ECP improve survival? And does it improve quality of life? Two really important questions for our patients. Well, it's sometimes difficult to pick apart whether a treatment modality is improving survival because some of the factors which are associated with a good response to ECP are also favourable factors for CTCL. So, you know, if you use it earlier in the disease, patients who respond with a lower white cell count, these are things which may be better prognostic indicators. So picking apart whether the treatment is improving the prognosis or whether the patients with a better prognosis do well with ECP is very tricky. However, a paper did come out of the Melbourne group in Australia, which did show prolonged survival with early use of ECP in patients with Sézary. So if it was used earlier in the course of disease, it seemed to be associated with a better prognosis. They use a slightly different regime to us in Europe, where they're using just one treatment every week rather than 2 treatments on consecutive days. And they found that the median follow-up from diagnosis was 48 months, with a median predicted overall survival of 120 months in those treated with ECP. And when we've seen that, you know, patients' survival is 3 to 5 years, obviously 120 months, that's 10 years, is a very good overall survival. The majority of patients commenced ECP as treatment lines 1 to 3 and as monotherapy. The use of ECP resulted in significantly longer time to next treatment when compared to alpha interferon, HDAC inhibitors, novel immunotherapy agents, low-dose methotrexate, chemotherapy. And in particular, early commencement of ECP at lines 1 to 3 yielded a time to next treatment of nearly 5 years. So time to next treatment I'll come to at the end of the talk, and it's a very good measure of clinical efficacy of a drug outside the boundaries of a clinical trial. And what about quality of life? Well, we studied this in 12 of our patients with CTCL on ECP, and we measured health-related quality of life using the SK index before treatment and then at 6 months after treatment. And we found there was a global improvement in their quality of life scores, alongside an improvement of their symptoms and emotions, but functioning was unchanged. So we concluded there was an improvement in quality of life after 6 months of ECP in erythrodermic CTCL patients, with significant improvement in both symptoms and emotion scores, and a trend towards improvement in those, or more improvement in those with a partial response or stable disease compared to those patients with progressive disease. So this is what we know from the literature. What do our guidelines say? Well, we've got a lot of guidelines, and similarly to what I was saying to you before, the good thing is they're basically all in agreement. And these are our UK guidelines, and they have ECP for erythrodermic disease, first-line option, stage 3 disease, as well as Sézary syndrome. And it can be used in combination as well as on its own, and it's particularly safe in combination with a number of different treatments. So our preference is with triple therapy with interferon and bexarotene, but you can combine it with methotrexate, radiotherapy, HDAC inhibitors, many other treatments without any adverse events. These are our European guidelines, pretty much saying the same. It's a safe and effective treatment for erythrodermic CTCL and MF and Sézary syndrome, and a first-line treatment option, often safely combined, and they also have it as a maintenance therapy as well. The NCN guidelines, as I say, I like them because they're updated regularly, and I felt I should put this up because these are all the people that work really hard to update them regularly, and I know Jasmine's on there as well, and you know, it really is testament to them. That's a big ask every 6 months, so thank you. And there's a slightly broader indications than the European guidelines for early stage under certain circumstances, including those with B1 blood involvement. Again, stage 2B under certain conditions, and B1 again is mentioned, and as the preferred regime in stage 3 MF and Sézary syndrome, but not recommended for nodal effacement or for those with visceral disease. So in summary, who do we treat? Well, it's safe and effective for patients with erythrodermic MF and Sézary, also used as a maintenance, a safe palliative option for patients if you want to get symptom control and can sometimes help with the itching. It can be used in monotherapy in patients with a lower tumour burden, or safely combined with multiple other therapies in patients with a high tumour burden. So there are CTCL guidelines on where ECP fits, but also to make everyone's life a lot easier, we've been writing guidelines specifically for ECP, how to use it, who to select, how to monitor your patients whilst they're on treatment. And if Rick Edelson is the father of ECP, then certainly Robert Knobler is our godfather of ECP. He has dedicated most of his life to this treatment and has written many papers and coordinated and first authored our guidelines on ECP. The first issue was in January 2014. Since then, we've updated them in 2020, and they now take two forms, Part 1 and Part 2 in the JEADV. And I draw your attention to cutaneous T-cell lymphoma, but it also gives you how to use ECP in all the other indications. But it suggests that you start off with one treatment cycle, so that's 2 treatments on consecutive days every 2 weeks, and you continue for at least 6 months and to gain a response. And then you continue treatment. You can tailor treatment, but generally our latest guidelines are to continue treatment until loss of response. And we also have UK guidelines, similarly selecting your patient selection criteria, your treatment schedule, monitoring protocol, and patient assessment responses. This is published in the British Journal of Haematology. So we have standardised treatment across the UK and Europe, with one treatment cycle consisting of 2 treatments on consecutive days, with treatment cycles repeated every 2 to 4 weeks. Patients tolerating treatment should receive a minimum of 6 months, and treatment should be continued in responders and in those with clinical benefit and stable disease. So if the patient is benefiting, they don't have to have reached the 50% improvement. They can be continued providing their disease is not progressing elsewhere. There's a real unmet need for safe and effective treatment of our patients with Sézary syndrome who have a huge symptom burden with painful, itchy lesions and a reduced quality of life. And we've heard about some of the treatment options. Photopheresis can be given with interferon and bexarotene, methotrexate, a very good, safe drug to use. It's easy, it's a once-weekly regime. It doesn't have many adverse effects. You can start it pretty much as soon as you're seeing the patient. If you're working them up for a diagnosis, there's no harm starting them on methotrexate. I also quite like doing that because then my patient has ticked the one systemic box. By the time if I get back, they've got nodal effacement, I can go straight onto brentuximab or whatever treatment choice I want. So it has a dual purpose there. HTAC inhibitors, which we don't have in Europe, but there's romidepsin, which is intravenous, vorinostat, which is oral, mogamulizumab, the anti-CCR4 we've heard about. A safe drug, very effective for Sézary syndrome. Brentuximab, it wasn't included, Sézary syndrome wasn't included in the Alcanza study, but for CD30 positive Sézary, there's no reason not to use it. I don't have enough experience yet to know how effective it is. Single agent chemotherapy, doxorubicin or gemcitabine, and then clinical trials. So who gains most benefit and what can we learn from our real-world data on ECP usage? So we'll look at the RetroClick paper by Pietro Caglino, the ProClippy data, and the time to next treatment data. trying to work out how we can best help our patients. So this is our dear colleague, Pietro Quaglino, who first authored the paper on global patterns of care in advanced stage mycosis fungoides in the Annals of Oncology. ECP was the most commonly used first-line treatment in advanced disease and the most commonly used second-line treatment, so tended to be used more upfront. But you can see from this beautifully multicoloured picture that there's a huge treatment heterogeneity in treatment lines for advanced stage MF. These are all the different treatments, and you can see what's selected first, second, and third varies incredibly. And that's because there's real heterogeneity within mycosis fungoides and Sézary syndrome. What did we learn with this large study, 853 advanced patients? We learned that there was up to 24 different drug modalities used as first-line treatment, 24. That chemotherapy as a first treatment was associated with a higher risk of death. The most commonly used first-line approach was ECP, either alone or in combination, followed by bexarotene and phototherapy. And ECP was also the most commonly used second-line therapy. And although there were significant differences in treatment patterns between the US and non-US countries, this did not impact survival. And this made us all feel a little bit better as we don't have as many drugs. You can just throw more drugs at them. The outcome's the same. But this is retrospective data. ProClippy is prospective data, so it's more up to date. We have nearly 2,000 patients and around about 500 with advanced stage disease. If we look at the patients being treated with ECP, there was 21 ECP centres, and there were 116 ECP treatments recorded, most of which, 81% in advanced disease, but nearly 20% of early stage patients were patients receiving ECP. So although our guidelines say one thing, when we look, we see something else. So guidelines are there for guidance. They're not a rule. Rules are there sometimes to be broken. So if we think it's going to benefit a patient, then we use it. It was tended to be used first line, 43%, second line, 30%. So most of the patients are receiving it either first or second line, with just a quarter of the patients receiving it as a third line or more. Median duration of treatment that was completed was 10 months. So again, this is useful information for our commissioners wanting to know when we start drugs how long a patient is likely to be on it. Partial response rate a little bit lower, so CR's 3%, partial response 38%, so a bit lower than the previous literature, but we have much more rigid guidelines now, as you heard from Dr. Zane earlier, for monitoring clinical responses and clinical endpoints. So this may be why 38% had stable disease. These patients also still had treatment ongoing, so some might not have reached a response yet. But as you heard from Dr. Zane, doing the proper response rate in patients with mycosis fungoides and Sézary syndrome is very lengthy, it's complicated, and needs very careful documentation. And in the real world is not a very good measure for measuring clinical efficacy of a drug. So we have this surrogate for clinical efficacy, which is called time to next treatment. And it's very useful because it tells us, it's defined as when you start one treatment to when you start the next treatment. So it includes how long you're on the treatment, but also how long you don't need your second treatment. So you may be on a treatment for 15 months, and then you come off it and you start your next treatment straight away. That would be a time to next treatment of 15 months. Or you might have a 4-month treatment with something, and then 9 months without anything. But you would still have the 9 plus the 4, 13 months time to next treatment. So it gives you an indication of how much benefit they're getting. And we really like it. And this slide, I think, really demonstrates how important it is. So here we see ECP treatments, 21% of our surgery patients in this study, often used in combination, with a response rate of just 34%, I say, which is not great. We think it's better than this. But the median duration of treatment in this study was 12.8 months, and the time to next treatment was 28.5 months. Now, if you look at the response rate of something like gemcitabine or doxorubicin, you see it's 78.6%. So you think, why are we using something that has a response rate of 30% when we have something with a response rate of 78%? Well, the reason is because that median duration of response is just 4.7 months, and the time to next treatment is 6.5 months. So in diseases that are moderately not high grade and we're not aiming for a cure, response rate is not a very good measure of efficacy of a drug. So this is our study with 178 surgery patients. Again, not surprisingly, multiple lines of therapy were used. These are the demographics of the patients. And these are our treatments. So ECP monotherapy was used in 9% and EC-based combination therapies in 20.2%. So ECP-based regimes was the most commonly used. And then if you look at the monotherapy of ECP, median time to next treatment was 8 months, increasing to 9.8 months in combination treatment. And interestingly, the 1 year free from next treatment was 20% in monotherapy, but was nearly coming up to half of patients with combination ECP therapies. And this improvement in combination therapies is not just seen with ECP, it's also seen with other drugs like interferon. So time to next treatment in this study for interferon was 4.8 months. But if you used interferon combination therapy, it was 9.2 months. So combining our drugs may be a better way of getting better clinical benefit to our patients, and working out which drug combinations are important will be very telling. And this just shows the longer time to next treatment in ECP-containing regimes, so the purple versus the blue of non-ECP-containing regimes. A longer TTNT after first-line combination of any combination. So combining our drugs was improving the time to next treatment, any combination, not just ECP combinations. So there, the time to next treatment of monotherapy was, or of combination therapy versus monotherapy was 10 months versus just 5 months, which is highly significant. And treatment line also influences time to next treatment. So if we're using ECP earlier, then it is a better treatment and has a better time to next treatment than if we're using it later. So what have I taught you? Well, what is ECP? Well, we've seen that it's removing your white cells, your buffy coat from your blood, adding a sorrel in and shining UVA light on it, and then reinfusing that buffy coat, expecting some of those malignant cells to have undergone apoptosis in the body, then to see those apoptotic cells and realize they're tumor cells and get rid of other tumor cells. Who do we treat? We treat erythrodermic CTCL, erythrodermic mycosis fungoides, Sézary syndromes. And although our European guidelines aren't indicating for early stage, certainly early stage refractory MF in real world data is being treated. When we've seen that earlier in the disease course, first line, second line, has better time to next treatments. And how we've learned the 2-week schedule, 2 treatments on consecutive days every 2 to 4 weeks. However, we know that if you use different regimes, such as in Australia and Melbourne, where they're using it weekly, it still is efficacious. So what does the future hold? Increased availability of ECP across the world, the provision of outreach services so ECP machines can go to patients, an increased number of indications, the treatment of pediatric patients. Now we have the new Celix machine. We can treat babies down to very low birth weight, 6-7 kilos. Not for CTCL, but for other indications. New combinations of treatment with the development of personalised medicine and the varied treatment schedule tailored to disease or treatment accessibility. So thank you.